Now, this is the most important slide. I put that in there to remind us because we're about 10 slides into this thing. And it's easy to get caught up in that data. And I can see some of y'all's minds whirling that you want to ask questions about, well, what data did you pull? Does that include this kind of therapy? Does it include nurse consultation? But I told all of you at the last work group meeting, we've got to keep our perspective the same as the people in this picture. And we're going to talk a little more in a minute about what's important to that mom and that daddy and that little kid. Probably the differences between CHMS and whether they can bill nurse consultation and DDTCS because they can bill transportation. Some of those are important and some of them aren't. Let's just figure out what's best so that if we have to look this mama in the face, we can say we did the very best we could. Now, y'all might be asking why I haven't talked about our First Connections program. Tracy Harris is here. She's our Children's Services Director. She wants me to talk about it. And I promised her I would, but not this time. First Connections does a good job of getting people in the system. They do a good job with helping our children who don't go to clinics, but that is a small number compared to the clinic-based service. And I want to get the big job out of the way first. We're going to come back at the next meeting and start talking about EI and how it fits into whatever model we figure out we ought to use. And I think it's going to play an important part. But you can see there at the first 4 bullet points, for the most part, those are the same. You go in either one of these places and your child, if they need it, can get PT, OT, or speech, and it's good stuff. They can get what we're calling, for the lack of a better term, specialized habilitation. That supports the therapy. That's with trained people who are used to working with people with delays. That's the one I get called out on when I go into meetings over at DHS all the time. I say, well, they're potty training them. Medicaid's not, now I'm just going to start yelling. Medicaid's not supposed to pay for potty training. And I use the example of, well, now, when we get an adult that comes into our program, whether it's at a Human Development Center or Pathfinder or Easter Seals, and they're in the waiver or even just in the day program, if they can't go to the bathroom independently, they have immediately cost taxpayers about $20,000 more per year for the rest of their life than they would have could they go independently. You guys, most of you guys in this room has been through it. You know I have. That take the Special Olympics basketball team up to the tournament in Russellville and take somebody that can't toilet independently. That's a real issue for a child. It is a monumental issue for an adult. Especially since about half the folks we serve are guys, and a lot of our staff, more than half, are not. So now we've got with a grown woman going with a grown man into a public bathroom, and that decreases people's independence, and that probably should end my 5-minute sermon about toilet training, but let somebody tell you it's not important. I want to see you jump down their throat like I do. Physician prescriptions, it's Medicaid, we got to have them. Nobody's arguing, that's fine. Now, both programs are certified by the Department of Health. They come in, make sure it's nice and clean, that we're not doing our best to transmit that ronovirus or whatever it is that's causing everybody to have the runs. And child care licensure comes in and makes sure that the swing sets are okay and that you got enough folks and that the toilets are like they're supposed to be. But then we get down to the differences. And I'm going to point out what some of them are that we're going to have to get our mind wrapped around and get a solution to. And then Anna's going to take that microphone and let y'all have a crack at it. DDTCSs have a deal where they can provide their own non-emergency medical transportation, which basically means they can go get folks and bring them back. And they can get reimbursed for that. CHMSs, some of them do it, but I don't think they can get reimbursed. In a DDTCS, a child has an IEP because those providers have agreed to be Part B providers. CHMS, I think the local co-op takes care of the IEP. We at DDS license and regulate the DDTCSs. We don't the CHMSs unless they're duly licensed. There are children who can qualify for services in a CHMS that might not qualify in a DDTCS. Somebody that's not necessarily disabled, but it does have a medical issue. I don't even want to go off into that. We got some therapists in here and some clinicians that are a lot better versed in that than I am. I will say that I don't think that ought to be an issue. If you can get in one, you ought to be able to get in the other, and that ought to be an easy one to fix. Now this one might be harder, but maybe not. DDTCS, the habilitation service, 5 hours is guaranteed each day. Now you can't go over 5 and get reimbursed, but there's no prior authorization, and that's in the law. In a CHMS, that is prior authorized, and my understanding is while it's not capped at a daily limit right now, you're given a certain number of units. It works out to about 3 3/4 of an hour, 3.75 hours a day. We got to get that. We got to meet in the middle somehow, or meet on one of the other ends. But I don't know that there's a reason to have that like it is. DDTCS by law has to be a non-profit corporation. CHMS does not. I don't know if that's a big deal or not. Who wants to go first? I want to hear some feedback about these differences and whether they're deal breakers or whether there's something you can compromise on, or did I miss something important, or do I just have it wrong?
Hi, I'm calling from Springdale. And the only thing, and I've recently located, I know everybody from Houston, and PD is my gig and all that wonderful stuff. So here's my question to you. Because I specialize in kids that are chronically ill and medically fragile. Do you not think that sometimes we need to be able to show, sometimes in pediatrics it's more, you don't see a lot of gains in like OT, PT, and speech. And is that something that we can, should we say that they have to be like adults and they have to have some gains? I mean, a kid, let's say, that has spina bifida or cerebral palsy, is nonverbal, microcephaly, has a feeding tube. Realistically, if we're doing OT, PT, and speech, it's almost custodial versus habitual, getting better.
I think that is definitely an issue that is fairly well talked about, and I think you've got a real point that there are kids who are not making progress and don't look like they're going to make progress. Our real problem comes from the reality that there are kids who do make progress. And if we could really pin down who is absolutely not going to get better, that'd be great. But my crystal ball has been broken on this one for a long time. So I think that's where our difficulties are. And maybe you could look at something over 3 or 4 years. If a kid wasn't able to make any progress over 3 or 4 years, maybe we need to reassess. But I don't have a great answer for that. I've seen kids who didn't talk for years and then started talking, but once you get out to be 8 or 10 years old, it gets much, much, much less likely.
Well, the only thing I would say to that is that's not the biggest percentage of who we treat. Those, right. The children who are very profoundly involved, who we can't really get them to show progress on standard tests, we have some clinical opinion options that are available to us to continue to service those kids.
That's a good point. You're right. Okay. Let me interject. No, I'm not going to get to Emma. Let me say one more thing, and I'm going to let you have it back. We deal with that. We've dealt with outliers in all of pavement improvement, the entire thing, not just DDS, and said that there will be small groups of people that we have to deal with individually. And I think that's what clinical opinion options are. And so I don't want to get hung up on that, but I know it's wrong. And I kept wanting, while y'all were talking, to do this, not that, this. Because if that's that child, we still need to help him and help that family. So we got to figure out a way to help him, even if he's not making any progress. So, but now, please go ahead. You were about to make a comment there in some other area.
Springdale? I totally agree with you, but I also have lived in countries where we have had national health, and some of the stuff that Medicaid is paying for is custodial. And that's all I'm saying is, I'll be the devil advocate here, even though I'm a pediatric nurse and I have advocated. I ran a respite program for families in Houston. But I'm just saying that when it gets to the point where it's custodial, why can we not say that or feel okay to say that to the parents or say no to them?
I've been in this a long time, and I know that there's times when we are, I don't want to say custodial, but we are helping people maintain skills. And I know that Mr. Ivers is around here somewhere, and he fought hard to get that into the definition of habilitation services. So there are times when we are trying to help people maintain the limited skills they have, and that Medicaid seems to have embraced that. They said it was okay to put it in the definition. So I do want to go back about that. We're not going to have a ton of kids like that, but we've got to know that we've got a way to pay for them. And if it turns out that we have to use money other than Medicaid to do that, we will. But of course, given our good match rate, I think we ought to always strive to. But I don't want to get hung up on it, since it is a small group, and Medicaid seems to be okay with paying for it now. I wanted to talk about it from a parent's perspective, and I am a parent, and unfortunately for Claire, everybody in Arkansas now knows she gets speech therapy because I keep telling on her. And I'm sure when she gets about 18, that's going to come back to haunt me. Or the first time when she puts me in that nursing home and forgets about me, and she'll remind me that it was because of that. But I know how Brenda and I felt when we went and talked about what kind of therapy and how much she needed and who was going to do it. And we, and most of y'all know Brenda works in this field too. That's how we met. She works over at the rehab center at Easter Seal. She's a QMRP. She's a licensed administrator. She's been doing this for 20 years. And she's really good at it. She's much better than me. She's like a lot of y'all sitting in this room. Well, between us, you think we'd know what to do when a child needs speech therapy, but when we were coming at it from a parent's perspective, we kind of panicked. And we didn't. We immediately said, she's got to get as much as she can possibly get, and then we'll pay for extra. And luckily, I know some people that do speech therapy, and I was able to call and say, I need help. And I basically put Claire's treatment in this lady's hands. And we're knowledgeable about what happens, and I can't imagine what those people, maybe they're not. I had a picture that had about 3 kids in it. Couldn't get it to paste into the thing, but I wanted to put it in there because a lot of times mamas not only are they overwhelmed with their child's disability, they got 2 or 3 other kids they're trying to take care of. And they end up having to go to somewhere that their pediatrician has pointed them at, or that their children's services nurse or one of Tracy's staff has said, have you tried going down there to the Francis Allen School or to Boast or one of those places? They'll help you. And when you walk in the door, you're kind of just throwing your family on the desk and saying, help me. So I think I've captured what that perspective is in this slide, that the people at either one of these places are going to help me decide why is my child being referred here? How are they behind? How far are they behind? What do they need to do to catch up?